So it's a great pleasure to wish you all welcome to one of the Global Citizen Lectures. I'm sure that you all know what the Global Citizen Lectures are all about. In fact, it's a new series of lectures that was introduced a couple of years ago, and the intention was to come up with lectures for the new students specifically, but it's an open lecture series, as we can see here today, that makes it very clear to the new students that when they enter an academic community like the University of Oslo, they also enter the global community with the responsibility that relates to being a member of a global community. So the Global Citizen Lectures are intended not only to prepare students for a global labor market, but also to tell the students in no uncertain terms that we have fundamental global challenges that any academic must relate to. Particularly, this addresses the needs for future leaders to really engage in the societal challenges that we all face. Today, we are extremely lucky because we have Jeanette Magnus here, who will talk about, as you will see, global health. Think globally, act locally. Most of you know what Jeanette Magnus stands for. She was educated, not at the University of Oslo, but at the University of Tromsø, now also called the Arctic University. She moved to New Orleans. You were there for 13 years as the chair and professor of a department in the Tulane School of
Public Health and Tropical Medicine.
Public Health and Tropical Medicine. And after having served as a chair in New Orleans, she decided to come here and to become head of the Institute of Health and Society. So we are extremely pleased that Jeanette is here today, and she will give a very good lecture, I'm absolutely sure, on a very important topic. But before giving the floor to Jeanette, I would just remind you that 2-3 weeks ago, we had Bill Gates visiting the University of Oslo. He came here. I guess he had many reasons for coming here. But one specific reason was to engage the young students in a discussion about, well, the global health challenges. Some of you might have been there, but this was a debate, an open communication, an open conversation in the old festive hall of the university. And I dare say we had a very, very good conversation about the challenges that we are facing now in global health. And I think what you will recognize today, that there are many different approaches to global health. One is the Bill Gates approach, to look for solutions to very specific health problems. But a much more difficult task is to see global health in a wider context, to look at the political determinants, to look at the root causes of health inequities in the world. And I think we are reminded of this when we look, for instance, at what happens in Greece today due to the austerity measures. We see that policy space for health is being reduced. We see that the austerity measures, they have a tremendous and negative impact on health. So whatever we do on the political scene, we have, and I think Jeanette agrees, we have to take health into account. And I think your lecture will bear on some of these extremely complex issues, how we could ensure that health is being taken into consideration when decisions are made, irrespective of political arena. So with this, Jeanette, it's a pleasure to introduce you to the audience and to give the floor to you.
Thank you. Thank you very much. Thank you for the invitation, or should I say the challenge. I really appreciate this opportunity. I chose the title, Think Globally and Act Locally, because I think we have to do that. And I'm going to use this hour that you have given me to go through the questions that you saw on the poster that I actually have posed to myself while preparing for this presentation. So the first question is perhaps, why global health? I'm educated as a physician. I have a doctorate. I'm a rheumatologist. I left to New Orleans and taught a lot of students. 82 nations came to the school. So I was living, breathing global health. And it's very okay as long as it is objective. However, suddenly, one day, the 29th of August, global health hit home. Hurricane Katrina hit New Orleans with huge force, and I became an internally displaced person for the first time in my life. And in the wealthiest country in the world, that was very special. An internally displaced person is someone who is forced to flee his or her home, but who remains within his or her country's border. After Hurricane Katrina, we were 1.2 million people that were displaced for up to 2 years. In 2011, it was about 15 million homeless due to natural disaster. If we add war and conflict, we add another 12 million people in 2011. So definitely, I got to feel something that many, many million people feel. But back to the hurricane. I'm sorry, but the wind and the water actually did not follow the speed limit. It was more than 35 miles an hour wind, as you can see, in this street with all the waves and in the water. We woke up the next morning, and New Orleans was the water city, as you can see from here. And to explain this, I've taken this picture, satellite picture of this intersection where you see the interstates, the highways, you see the houses, you see the greenery, and then suddenly there is nothing but water except for the highest points. It was between 1 meter and 4.5 meters of water all over the city, standing water for 2.5 weeks. So the communications, everything was not working. Cell phones were not working. Nothing was working of any kind of communication, but you could write on your rooftop. Mother, sister, and wife, 3 children, 8, 12, and 14, 9-month baby. No food, no water, please help. You had to climb to the roof in order to avoid the water. And just by the Coast Guard alone, 9.5 million people were lifted within the first week after the storm. Many of you might have been to New Orleans, and the area that is within the yellow dots is actually what was flooded. It's perhaps easier to take this area and juxtapose it upon the Washington, D.C. Some of you might have more likely been there, and you see the large area. When I say that it was close to 500 square kilometers, some of you might understand how much that is. Oslo, including Nordmarka, is actually 545 square kilometers. So the whole of Oslo, Oslo Kommune, Oslo County, was underwater. That's for 2.5 weeks. That's how it was. So this is my workplace, where we then had to use boats for about 2 weeks before the water subsided. In the aftermath, there was nowhere to go, except what we call the sliver by the river. That was the only place that was actually at sea level. And particularly for women, infants, and children, this was horrible. It took time before President Bush came on the television and said that this was one of the worst disasters to hit the US. But what actually happened in front of your eyes and of mine was actually to demonstrate how ill-prepared the state of Louisiana and the federal officials were in response to a catastrophic event. Very often, when it is a catastrophe, we think, yes, there is this thing about martial law. Martial law is then the imposition of military rule by military authorities over designated regions on an emergency basis. However, that didn't happen with us for several days, because who can do it? Is it the President of the United States who can call martial law in New Orleans? No. Is it the governor? No. It is actually the local sheriff that can do that. And it took time. For some of the small counties, they had to find him because he might have evacuated as many others. So it took time before the military presence came to town and was then actually giving us some stability. You can imagine a city with about 500,000 inhabitants, where all people that are dependent upon drugs, alcohol, or whatever go sober within the same 48 hours. What happens? That is what added to our really, really strong catastrophe, in addition to people not having access to food and water and regular things. It was special when the television could show people wading through water, carrying television sets when there was nothing to do. Another thing when it comes to local policies was actually we needed help, because many of the physicians had also flooded. And then comes the problem of medical license. That is what's bestowed either by a specific government, approved professional association, or a government agency, so that you're licensed to practice. This is the Astrodome in Texas, where 25,000 people lived for more than half a year after the storm. And there was, who was to look for them? Came a crew of about 100 people from Mexico, with nurses, psychiatrists, regular physicians, etc., etc. They could not do anything because they were not licensed in Texas. Another thing when it comes to local policies that really hit home was the dead bodies. What to do? The law is that a coroner, who's actually an elected government official, who confirms and certifies the death of an individual within a jurisdiction, has to perform the autopsy according to Louisiana law. And that's one person. So the number of missing, the number of casualties are not actually reported until the autopsy is finished. So we heard, oh, there is 115, there is 145. Every day the number were rising, even though we knew there was 1,500 bodies in the morgue. So this is policies. This is not health. A woman in a shelter in Louisiana that we talked to after the storm said, so I'm here homeless. I'm trying to find my niche in life. And I guess the most stressful thing is for me to see this beautiful city abandoned by those who have the wherewithal to bring it back. The state, the federal government, everybody failed Louisiana. And you all saw it on television. So, of course, we didn't have as much risk for cholera and infectious diseases, but we can document increased mental health problems in the years after Katrina. We can document increased mortality, heart attacks and stroke, and suicide, especially among young people and men after the disaster. And there is no reason to believe that this is not what's going to happen or actually do happen in other disaster areas where they do not have the same ability for surveillance. For instance, in the Philippines. Seeing the pictures, seeing the footage from there is like reliving what we saw when in 2005 in New Orleans, but in a larger scale. We were just 1.2 million that were hit. In the Philippines, it's 13 million, ladies and gentlemen. So please remember the Philippines as you now approach Christmas and holiday and celebration. This message is also from a woman in New Orleans after the storm, and it's a message to all people who come back, all people who try to rebuild their lives. Let them know that there is no quick fix. We can start you on the way. Let them know that there is hope, but there's no quick fix. So lead them on the way, and never to take and build up a person's hope, false hope, to hurt them, that they will not go further to find help. I think that's what caused a lot of people to have more stress than me. They commit to certain things because people have led them to false hopes. So, ladies and gentlemen, what is global health? I'm sure many of you thought I would talk about diseases, like this young man here, who has a disease that we currently do not see in Norway. Anybody would guess for the diagnosis? I found the picture on Medical Pictures Info. He has lepra. He has what's known internationally as Hansen's disease. Armauer Hansen was a physician who was studying leprosy and identified the bacilli that actually causes leprosy to be contagious and go from person to person. And guess where he worked? In Bergen. The largest leprosy hospital in the world was in Bergen. The last person who died with leprosy in Norway died, any guesses? In 1972. So it's not that long ago when we also had these kind of diseases that some of the developing or the low income and middle income countries have now. Leprosy is one of them. There are other diseases that you think of that they have more than us, but we had them 100, 150 years ago. Norway's infant mortality, the number of children who die after birth, was actually not that much lower 100 years ago, 70 years ago, than there is in some developing countries today. You think that diabetes is only in our country, but the largest growing population of diabetes is actually in Asia. So, global health, the diseases, it's a matter of time, but it's also a matter of how we think. So, ladies and gentlemen, I challenge you to listen to this woman from Venice in Louisiana after Hurricane Katrina, who said to us all, first of all, we have to change the way we think. I know it's hard to do that, y'all. I know it is. But that's what keeps me sometimes, because I keep on focusing on where I'm hurting, of course. And if I keep on saying how I'm hurting, you know, of course I'm going to be hurting. But we have to change the way we think first. And when you change the way you think, then we'll change the way we act. And then we'll change the way we feel. And that's what we have to do about health. Human health is the integrated outcome of ecological, social, cultural, economic, and institutional determinants. And this is very nicely put in a figure where you can see actually that, of course, the biology of diseases are in the center, and all the individual things that we often think of as the key elements related to our disease. And of course, the behavior. We all know, exercise more, don't smoke, don't drink too much, just a little bit, you know. And it's very important also with family and social networks. The other thing that in this model is presenting is that actually living and working conditions has an impact on your life. In addition, around all of these things comes the broad social, economic, cultural, health and environmental conditions, as well as policy at the global, the national, state, and local level. All these things play together to actually create health. So global health, ladies and gentlemen, can be thought of as a notion, the current state of global health, as an objective, a world of healthy people. You know, that's the goal we have when it comes for global health. Or it can also be as a mix of scholarships, research and practice, with many questions, issues, skills and competencies, and all that together is global health. Usually when we look at a map, we see it like this. But luckily for us, World Mapper has made it so that we can look at it also to look at the total population in some of these countries and look at what happened to India and China. We can also look at wealth, and suddenly Africa is gone. You know, there is Africa. That's how it looked like. There's the population, and if you look at wealth, it's completely gone. So the association between health and wealth should be evident. But perhaps you didn't know that it's only in the early stages that we actually, in economic development, that boost life expectancy. That when you come up here at around $10,000 a year per person, it flattens out. And of course, Norway is all the way over here. There is dramatic inequity that dominates global health today. And you just need to read the news in order to see that. Because, and we can illustrate it this way, the global village. I'm sure you know this. If we could shrink the Earth's population to a village of exactly 100 people, with all the existing human ratios remaining the same, the village would look like this. There would be 57 Asians, 21 Europeans, 14 from North and South America, 8 Africans, 51 would be female, 49 be male, and 70 would be non-white, and 30 white. And 50% of the entire world's wealth would be in the hands of only 6 people, and those 6 would all be from the United States of America. That's our global village, ladies and gentlemen. That's the wealth. Desmond Tutu said in 2007, in a world that is so divided by inequalities in wealth and opportunity, it is easy to forget that we are part of one humanity. I like history. I'm not as good in history as our rector, but I wanted to give you this poem. This is Bertolt Brecht's A Worker's Speech to a Doctor. When we come to you, our clothes torn off us, and you listen all over our naked body as to the cause of our illness. One glance at our rags would tell you more. It's the same cause that wears out our bodies and our clothes. The pain in our shoulder comes, you say, from the damp, and this is also the reason for the stain on the walls of our flat. So tell us, where does the damp come from? Poverty. Of course. Income inequality is very, very highly related to health and social problems. So if you make an index of all the things listed here, life expectancy, infant mortality, imprisonment, teenage births, level of trust, obesity, mental illness, and social mobility, and plot that against income inequality, you can actually see what happens in certain countries. In Norway, so far, we are lucky. We're down here. We have low income inequality and we have low index. We are on the good side. The US is by itself all up there. And it's interesting to know, if you read US history, you will see that the inequality in the US has grown dramatically over the last 50 years. Really, really dramatically. Diseases that was non-existing, nearly close to, of course it's 300 million people, so they have some of it, but it was not an issue about 20, 25 years ago, and now it's huge. So these things is what we have to pay attention to, because it actually is an indicator of growth in different problems. We can also look at just at the neighborhood. Which neighborhood do you live in? Where life expectancy and disability-free life expectancy at birth, which is the light green one here, the dark green one is plotted where you have more deprived neighborhoods compared to the least deprived ones. And you see it ranges from 52 years up to close to 70 in disability-free life expectancy at birth, and life expectancy from about 73 up to over 80 years in the more affluent areas. We can find this also when it comes to under 5 mortality in not so wealthy countries as well. We find the same thing here. I'm showing you the differences in the death of children before 5 years of age, just by looking at the rich all the way down to the poorest. And you see there is inequality in each country, even the low and middle income countries. What about Oslo? We know that expected life years in Oslo differ with 12 years among men from the west to the east. The men are the darkest ones here, with 72 years, live a little longer. The women up in the west live a lot longer than anywhere else in Oslo. So even here, we have it. So the question is, does global health affect you? Living in Oslo, does it? Yes. Who did not fly the last year? 1 or 2 of you, perhaps? Most of you did fly. And it takes few hours to go from one part of the world to the next. And so does it for pigs. Swine can also flew, and they flew big time not long ago. And now there are other diseases that they are monitoring, that they are really afraid shall start flying like this one did. I want to talk to you about the importance of girls. Why? Why are girls important? They are the ones that in some countries they abort if they are pregnant with a girl when they can and can afford to get a test. They are the ones that they kill in some countries because they cannot afford to have a girl, that they have to pay a dowry. But girls are actually extremely important if any country, any state, any area wants to grow, wants to have economic development. The number of illiterate young women over the world, you can see, actually follows pretty much the poverty line. If you look at changes in literacy between the countries that have had economic growth and those that have not had, you will see that there is a clear association between economic growth and the increase in prevalence of education in young girls. If you look at infant mortality, I've given you just one slide. This is actually from Brazil, where you actually can see the difference from non-education to 8-year or more schooling. And here I've shown you also the difference whether your skin is white, a little darker, that you are mulatto, or you're black. And you see within each category of educational level, there is a gradient also by your ethnicity or your ethnic belonging. So there is a social gradient in health that exists within countries as well as what we usually think between countries. We have accepted that there is something between countries, but there is within, and it's within here with us in Norway. So back to our model. I really want to focus on the last two and to present to you a work that was published a little while back, and to introduce the term social determinants of health, which is actually social, physical, economical, and service-related determinants. It relates to income, education, ethnicity, the built environment, the houses, the streets, and so on, level of stress, perceived stress, level of network, social support, the percentage of children that actually had adverse experiences in their early childhood, employment and housing, transportation, food environment, social standing. All of these actually comes together and actually can identify health equity and can be used as a developmental outcome. Because the development of a society can be judged by the quality of its population's health, we have talked about that, the fairness in distribution of health, and the degree of protection provided from disadvantage due to ill health. How well do we care for those who live within our borders? So closing the gap in a generation came in 2008, and Michael Marmot was the head of this committee, this commission, and has actually said that there is an opportunity to tackle the social determinants within one generation to make it go away. And what he then draw our attention to, this is a different way of actually saying the same as I did with my circle, with the individual, community, policy, and environment level, and he calls for policies on all different levels that actually would guide you and support you to actually do differences. So another conclusion so far in the talk is that economic and social policies do matter for health and health equity. Then the question becomes, are the challenges of global health absolutely insurmountable? Are they too big? Is it true? Can we do this in a generation? Is it possible? Yes. Last week, December 3rd, came a new report, Global Health 2035, a world converging within a generation, the Lancet Commission on Investing in Health. Very interesting. They could then, their starting point was that under 5 mortality rate has significantly changed. Actually, we can see that there has been a reduction. Of course, the least reduction is in sub-Saharan Africa, but all other places, the reduction is between 1/3 and all the way up to 51% in mortality. And that means there are things changing. If we had put this table on top of girls' education, you would see that the areas that changed the most were some of the areas where more girls were educated. So there is hope if we do something for these girls that are about 4 or 5 years old. They are more likely to survive now than just for 15, 20 years ago. Their conclusion of this report is that there is a very large payoff from investing in health. Health improvements account for 11% of economic growth in low-income and middle-income countries. But between 2000 and 2011, it accounts for 24% of the growth can be dedicated to health improvements alone. Their second conclusion is what is mimicked in their title, that there is a grand convergence that is achievable within our lifetime. With the right investments, differences in infectious, maternal and child death rates between countries of different income levels could be brought to an end within our lifetime. The other thing they said is that scale-up of low-cost packages of intervention can enable major progress in non-communicable diseases and injuries within a generation. So both infectious diseases, maternal and child health outcomes, non-communicable diseases, diabetes, heart disease, hypertension, and injuries can be reduced in some of these high occurrence countries. The last suggestion by the Commission is that it endorses progressive pathways toward universal health coverage that are pro-poor from the outset. And they have not done it in a very nicely way, demonstrating how this actually would be economically beneficial to the countries who choose to do this. So, we have the right answer. We can be the best ones in class. We have the right answer. And what then about Norway? What should we do? The president of the World Bank, Jim Yong Kim, as a comment to this commission, wrote in the same issue, "We must also look for solutions beyond the health sector." Because health is not only a sector contributing to other sectors, health is a social objective of security, education, environment, etc. Health needs to be moved from an instrumental to an intrinsic value. And that is our challenge. That is the challenge to each one of you. The leader of the World Bank said, furthermore, that governments must lead the way, but governments cannot do it alone. The private sector, international organizations, foundation, and civil society all have key parts to play. Policymakers need to harness the resources and the innovative approaches of these multiple actors, working in concert with a vibrant public sector. So that's the challenge. Another one comment was that the Lancet Commission recognizes it, but chooses not to focus on the multisectorial or social determinants of health because complex and entrenched political obstacles exist to addressing them. It might be that they were not bold enough. Global governance for health is a challenge. There is not a single light that actually shows you the way. But luckily, there are somebody who actually dared to do this, and that's the Lancet University of Oslo Commission Global Governance for Health. It was 18 members, 16 different countries and 5 continents. They were experts in a wide variety of fields relating to global governance and health, such as trade, environment, human rights law, war and conflict, public health, epidemiology, diplomacy, political economy, and even more. And the chair was our rector, Ole Petter Ottersen. So there was somebody who dared to start talking about the elephant in the room that nobody wanted to talk about. So I'm pleased to say that actually the Lancet University of Oslo Commission on Global Governance for Health is in press. It's going to be published in the Lancet, and it will come the 11th of February. And the title is Global Governance Gaps, Propagate Health Inequities, Political Determinants of Health. We have talked about the political determinants of health pretty much since we started. But this very nice report gives 5 very special cases that they discuss, and then they analyze and come with very exciting recommendations. Because health is all about politics. Here's one. The Bhopal gas tragedy. Who's responsible? For those who remember this disaster in India. Marketing of unhealthy foods and the accumulation of power among transnational corporations. Here are 2 kids enjoying a super meal at a local fast food restaurant. What then about water? We heard a little about it in the news the other day, about people buying water now from one of these big companies because their own water sources have been depleted. So here, the right to water or Coke. Why on earth would you need water? Simply drink Coke. Another thing here, it says, it's agribusiness contributing to food crisis, and you see this is ethanol that is produced by corn. So my car too is hungry. It's the comment. So how's your relationship to policies that impacts food. There is policy challenges all over. Good global governance, there is political empowerment, inclusion and voice. It's important to think about gender equity, fair financing, market responsibility, and there has to be health equity in all policies, systems and programs. So the committee then came to some conclusions. They said that power asymmetries create dysfunctions that allow adverse effects of global political determinants of health to persist because, mainly due to democratic deficit, weak accountability mechanisms, institutional stickiness, absence of nascent institutions to protect health, lack of policy space for health. Each of these is actually very nicely laid out and discussed in the paper. Health and well-being subordinate other societal objectives. And you can see that by the difference between those that have-nots and those who have. One of the things that the Commission report says, it calls for an agenda for change. It calls for cross-sectoral global action for health. It suggests a multi-stakeholder platform on the governance for health. It suggests a policy forum that could provide space for diverse stakeholders to frame issues, set agendas, examine and debate policies in the making that impact health and health equity. Why don't we always, when we institute a new policy, think about the health implications? Or if we make a new treaty, the number of treaties over the last 15 years have increased with several thousands among the multinational companies. And I don't think when they sign a trade treaty that they discuss what kind of implication could this have for health. Yesterday, I had the privilege of attending the NORAD conference on knowledge and education. And Amina Mohammed, special advisor to the UN Director General, said, "We cannot go where we are going unless we know where we're coming from. We need baseline data." Yes, in Norway, we're pretty good with that. But the problem is that if you have no data, you actually have no problem because it doesn't show, and you cannot create any kind of action because what to do when you don't have any data to guide you. So the committee suggests an independent scientific monitoring panel for a global consortium association of academic institutions to track progress of on governance and health indicators to feed into formal governance processes and create accountability along standards. But at the heart of the Commission report, and also during the meetings, it was very evident that behind every government is its people, and that it is the people's best at heart that this Commission and the report actually try to frame. Governance should be focused on delivering results, not on achieving the perfect arrangement of institutions, was said by Richard Horton before we embarked on this adventure, and truly we have stayed on that course. There is another thing then, if we're taking it all the way back home again. Investing in health is about holding ourselves accountable. And then the question comes, and I have the privilege of then asking Rector, what about education? What about the future? What is global health is something I've talked about. So the conclusion is it's an area for study, research and practice. And the point is to improve health and achieving equity in health for all peoples worldwide. It emphasizes transnational health issues, determinants and solutions. It involves many disciplines within and beyond the health sciences and promotes interdisciplinary collaboration. It's a synthesis of population-based prevention with individual-level clinical care. It warrants coordination across sectors, as we have talked about, and international collaboration. So, dear Rector, should global health be on the educational agenda at the University of Oslo? I Googled University of Oslo and global health, and was flattered that actually the thing that came up was this talk. A few other things. The International Community Health Program that we have at the Institute of Health and Society came up. A few other things, but not much, dear rector, not much. And when I then switched to find the pictures that were going with global health and Oslo, these two ladies came up. So that's what's associated with global health and Oslo when it comes to global health. So the disciplines involved in global health is social sciences, behavior sciences, law, economics, history, engineering, biomedical sciences, environmental sciences, political sciences, etc. So what do we do with that? What do we do? Do the current education strategies prepare for the challenges in global health? No. And I then have to ask, we'll do that later, what part of the no you didn't understand when we discussed this. I want to challenge you with Einstein. The world we have made as a result of the level of thinking we have done thus far creates problems we cannot solve at the same level of thinking at which we created them. It sounds as if this is a challenge for a university and for the University of Oslo. So it's time for change, and change is a process and not an event. So my suggestion is that we have a transdisciplinary educational program at the University of Oslo that actually has a bachelor degree, and I place it at my own Institute of Health and Society, a master's anchored in an international Masters of Public Health model with different major opportunities, one being global health, a PhD at different faculties with transdisciplinary credit seminars and courses at Leve here at the University of Oslo. And if you want it in writing, dear rector, you'll get it. I'll leave you also with Richard Horton's commentary at Lancet the 3rd of December. He said, beyond global health, planetary health includes global health, but it adds two further dimensions. One is the health of the physical planetary systems our species depends upon for life. Another is the health of the human civilization we have created and which, as history attests, can so easily collapse. The health of these two systems can be summed up in a single word: resilience. Investing in health means investing in resilience. Health without resilience is unsustainable. Thank you.
You were talking about Bill Gates' approach to health. My name is Randi Ness, and I represent the life-living approach to health. It's a service or value-driven service innovation. In a way, it's a kind of cross-functional, cross-sector approach, as you were talking about. The question is, I saw a few days ago that the World Health Organization put stress as number one health factor in this century. And I also saw that 70% of young leaders say they have been close to being burned out. And I think that's a challenge. Do you have any reflections, comments, or thoughts about those questions?
Thank you. Thank you very much. You point to a very, very important issue, and that is the causes of the causes. Okay, stress. When you take mental health, depression, stress, and you look at the causes of the causes, so then I mean the causes of hypertension, blood cancer, myocardial infarction, heart attacks, strokes, and so on, you will get stress, mental health issues, you will get tobacco, you will get overeating, etc., etc. So that's the causes of the causes. When the World Health Organization sent out their new report, they actually rank at the top stress and mental health issues as the root cause to a lot of diseases, both in developing countries and in rich countries. Although our reason for stress in Norway is something else than where you don't know if you have enough food, for instance. So I think you're right there. So we have to actually make sure that people have enough food, that they have enough to eat, and they don't need to be afraid for that. And we have enough food. We produce enough food for about, what was the last I saw, about 9 million people. Today we produce enough food for 9 million, and we're only 7. So, billions, I'm sorry, billions. So we have enough, but we don't share it. So I think you're right. We have to have a holistic approach, and that's what I've tried to say, that it goes all the way from the individual, all the way out to how they work down in Stortinget or World Health Organization or other places around the world where they make decisions. Will you answer my question, Rector?
Well, I think I've done this already. Well, this is the closest you can possibly come to an ambush in an academic setting. So I was not prepared for your question, but as you know, we have already taken quite a lot of measures to satisfy your wish when it comes to a more, let's say, focused engagement in global health. So one thing that has been decided not long time ago, in the university board, in fact, after our initiative, is to develop an Oslo School of Global Governance, which in fact will tackle many of the issues that you raise here, the deep root causes of health inequities. And I'm absolutely sure that global health will be very much in evidence in this Oslo School of Global Governance. Of course, it will be multidisciplinary. It will deal with global governance as such, but as you have detailed for us, global governance is very much about governance for health. So the more specific global health initiatives, I think you have to look onto your own faculty and your own institute. So I would return the question to you. What are your plans when it comes to global health at the University of Oslo? In other words, we have to interact and we have to collaborate on very many different levels within the institution to ensure that some of these challenges that you so eloquently described to us, that they are adequately tackled also within our own institution. So what I also would like to say is, of course, that this Commission report, I think, will help build new initiatives within our institution. Because I think there is a demand for this Commission report. I think there is a demand for the awareness. You said we have to think differently in order to act differently. And one of the most important things about this report, I think, is to instill awareness of the fact that many decisions made beyond, as you said, the health sector, they see really and negatively impact health. So I think we will see in the future a University of Oslo that is much more prepared than it is today to tackle some of these challenges, and you will be an instrumental person in this. I also should say that some of the persons behind this Commission report are in this very room. Desmond McNeil is, of course, one of the commissioners, and Anne-Louise Lee, you did a fantastic job. And Jeanette herself, she's so modest a person. So she didn't tell you that, in fact, she has been an inspiring force behind this commission. So we have to continue this discussion in a different setting. But I should tell you that global health, and now you have to applaud Jeanette. Global health will also be the issue of the next lecture in this series. Thank you, Jeanette, for a very eloquent talk about a very important issue, and we wish you all the best for the time to come. And might your wish come true, that global health will be one of the most important issues in the life of the University of Oslo. Jeanette.
Thank you very much.